Hello, everyone, and welcome to another episode of Let's Talk Hereditary. Dr. Church, thank you for being with us today. Our topic today is FAP. We're going to talk a lot about this, but today I wanted to focus about surgical treatment for patients with FAP. So what are the surgical options that we provide for patients with FAP when they present to us?
Okay, so the main concern about surgery, at least initially, is to control the colon and rectum. So we'll talk about colorectal options. And that depends on the polyp burden or the number of polyps in the large bowel. So I'm assuming just for the moment that we can't control the large bowel endoscopically. We don't want the patient to get a cancer. So we have to remove the colon so that the many polyps that are present in there don't get a chance to transform into a cancer and then spread and then have bad effects on the patient. So there are three main options for removal of the colon and rectum. The first is to just remove the colon and leave the rectum, which is the lowest 8 inches of the large intestine. Arguably the most important part of the large intestine because that controls going to the bathroom. So we leave that behind, we join the small bowel onto the rectum, and that controls the risk of colon cancer. There still is a risk of rectal cancer. The second option is to take out the entire large bowel, the colon and the rectum. So then we have an issue that we've taken out the part of the bowel that controls going to the bathroom. So about 40 years ago, some clever doctors invented a way of replacing the rectum by making an intestinal pouch. So we would make a pouch out of the small bowel, sew it down to the bottom end, and then we have a way of controlling going to the bathroom. So we can remove the entire colon, the entire rectum, and still go to the bathroom the normal way. So that's called the ileoanal pouch operation. The third option is to remove the entire colon, the entire rectum, and just give the patient a bag or an ileostomy. That's less complicated. It has a very predictable result and absolutely guarantees that that patient's never going to get a colon or rectal cancer in their lives.
When you mentioned those three options, I want to focus about the first and second option first. We talk a lot about the rectum and rectal polyps. Not all patients will qualify for a pouch from the beginning, and not all patients will come to you and you say, I can just take your colon and preserve your rectum. So who are the patients that you say, I will be able to preserve your rectum and I'll give you a total colectomy with an ileorectal anastomosis?
Okay, so we've done some research in this at the Cleveland Clinic some years ago, but it's really held up. And that is we grade the patients according to the number of polyps in their rectum. So if there are less than 20 adenomas in their rectum at the time of surgery, we can leave the rectum behind and be quite happy that as long as the patients come back afterwards for yearly checks, that they're not going to get rectal cancer and we're not going to have to take their rectum out later. If patients have more than 20 adenomas in their rectum at the time of surgery, then probably the better operation in terms of cancer control and polyp control is to remove the rectum at that stage and do a pouch. So that's not an absolute rule, but it's an indication. And that will control the cancer tendency while at the same time not having to come back later and have their rectum taken out.
So tell me a little bit about the quality of life for patients that get either surgery, which is total colectomy with an ileorectal anastomosis, an ileal J pouch, or just an end ileostomy. How does their life is different?
So when we're talking about quality of life in surgery, we relate it back to what their quality of life was before the surgery. And in FAP, a lot of patients don't have any symptoms. We're doing what we call prophylactic or preventative surgery. We're not treating the symptoms in general. Sometimes we are treating symptoms, but most patients have what we would call a normal lifestyle or a normal quality of life. And then we come along and take out their colon. So what does the colon do? It absorbs water from the stool, it packages the stool, so we only go once a day. So the main difference is when you take out the colon, and it's particularly if you leave the rectum, the stool is a bit mushy. It's never going to be perfectly formed. And then you go more often. So after an ileorectal anastomosis, the average number of bowel movements a day is 4. But you should have good control. We're not doing anything to the sphincter muscles. And over time, the body adapts. The body is a marvelous machine that can adapt to a lot of things we do to it. And the quality of life can be very close to normal. We especially like to do this operation in children because it's very important for them to have a normal quality of life when they're going to school, when they're going to college, when they're playing sport, and when they're dating, and when they're just in the formative years of their life.
We mentioned initially that FAP is a syndrome. Are patients free of disease after their colorectal operation, or they still need to come and see you again?
So because this disease is present, at least the cause of it is present in every cell in the patient's body, we can never cure them of the disease, never. Can we cure them of cancer risk in the large intestine? Well, we can't if we leave the rectum behind, and we can't even do that with an ileoanal pouch because there's always a tendency to get more polyps in that little bit of rectum that's left to do the anastomosis, and also polyps will develop in the pouch itself. So regardless of what surgery is done, patients need to be checked. Even patients with an ileostomy can get polyps on the ileostomy, although it takes many years for that to happen, but there are reports of cancers in an ileostomy. So patients should never think that they can just go away and never see the doctors again. They always need to come back once a year and have everything checked.
What type of follow-up from a colorectal surgery standpoint do those patients need?
From a colorectal viewpoint, if you have a rectum, you need a yearly proctoscopy. We usually do it with a flexible scope, and then to treat polyps as necessary. With the pouch, a yearly pouchoscopy, and with an ileostomy, usually the colorectal follow-up is not really appropriate because there's no colon or rectum, but it's a good idea to keep an eye on the ileostomy when you come in for your stomach and your duodenal checks.
The word chemoprevention, when we mention polyps and talk about FAP, floats around a lot on social media, on the internet, and even in recent literature. Tell us a little bit about chemoprevention for polyps in patients with FAP.
So over the years, really starting in the early 1980s, we found out that certain drugs can stop polyps from growing. Nothing will stop them absolutely 100% of the time, but there are many agents that will slow down their growth. For example, one of the most common and easily accessible agents are non-steroidal anti-inflammatory drugs, and in particular one called Sulindac or Clinaril, and we do use that from time to time to slow down the growth of drugs. Because the polyp growth in FAP is quite rapid, there have been many trials done testing various agents. So celecoxib is another one. It's a variety of non-steroidal anti-inflammatory drug that also retards the growth of polyps. We've done trials of fiber to see if that will do it, of raspberry suppositories to see if that will do it. Many other drugs, and trials are still going on. But the essential principle remains that nothing works 100%, so you still need the checks, even if you're taking polyp suppressives. And there are roles for chemoprevention in very young children that may not want to be operated on immediately. We can suppress the polyps for a year or two. There's nothing wrong with that. In patients with a pouch that get a lot of polyps, they need treatment, and I treat them routinely with Sulindac to keep the polyps under control.
So people who are watching us will notice that we're going to talk a lot about follow-up. But if you have a patient that calls you and says, I'm on a chemoprevention medication, I think I'm doing okay, last colonoscopy was fine, are they free to not follow up with you, or they still need to see you?
They need to continue their regular follow-up. One of the things about these non-steroidal chemoprevention drugs are they're very dependent on good compliance with taking the medication. So if you forget your pills for a couple of days, the polyps will come back. And then first thing you know about it is you've got big polyps again. The other aspect is that there have been at least 5 case reports now of patients whose polyps have been suppressed by non-steroidal anti-inflammatory drugs, but have got a cancer anyway. And that takes 10 years or so to happen, but it can happen. So the best thing to do is always get checked.
Dr. Church, thank you for being with us today. Thank you everyone for tuning in today. I'm your host, Mohammed Abbas. Again, if you have any questions or any concerns or any ideas, direct message me or find me on social media or call us at the Jagelman Registry at the Sanford Weiss Center at Cleveland Clinic. Thank you.